So a couple different detox types we see in facilities. The first is symptom targeted withdrawal, and that's going to be dosing a patient based on their withdrawal symptom, based on their CWA scores. So you may see something that says CWA score 8 to 12, give a half milligram, CWA score 12 to 16, give 1 milligram, etc. And then we have tapers. I like tapers because you know what they're getting. It's very orderly. It's over a course of usually a few days. So some hospitals may have different protocols for tapers. Say you may have a physician that does like a volume A or a volume B, and they have different standards for each one of those tapers. Now, personally, I like the tapers because you don't have to rely on secondhand data. Say you have nurses that are new, or they're missing things, or they're just kind of not up to speed in detox. Maybe they worked in another unit. Maybe they're scoring them very low on the CWA. They're actually a lot higher. So there's a lot of room for interpretation when we look at CWA scoring. But when we have a preset taper, we still want to do the CWAs, of course, but we know what they're getting, and we have enough patients under our belt. We've seen that protocol work for many people without seizures. For instance, some facilities will use Librium, so I've seen that a lot. So you'll see maybe a 100 milligram loading dose, and then 50 milligrams 4 times a day, 50 milligrams 3 times a day, 25 milligrams 2 times a day, 10 milligrams at night. Just kind of off the top of my head, something like that. I'm sure most people, and this would be a healthy debate to have, I'm sure most physicians would probably like a tapered approach. The problem with a tapered approach, and feel free to chime in, this is my experience, is they're usually not scoring high in their CWAs because we got them on a nice taper. They're very comfortable. They're not experiencing a lot of detox symptoms. They're medicated, they're managed. But the problem is a lot of insurance payers, if they're not scoring above an 8 on their CWA score for a certain amount of CWAs in a row, they'll cut detox coverage because they'll say the patient is not detoxing anymore. You need to move them on to their next level of care. So it's difficult, especially with tapers, because if you do have some managed care organizations and some private payers, if they are scoring low on their CWAs for a few scores in a row, and it's different payer, some of them may be 3 in a row, then you have to step them down that level of care. So it kind of sucks that we're forced at some places to use symptom targeted, because you're like basically constantly giving them Ativan, waiting for their CWA to go up, giving them Ativan, and then getting them through that detox period. It is quicker. You can get them through it a little quicker like that. But again, there's a lot more risk to the client because you're constantly on the edge of how severe are their symptoms, how are we going to medicate them, and then we have that room for interpret depending on the nurse who's doing the CWA assessment, or if they miss something, then a lot can go wrong. So would love to hear you chime on the tapered approach and the symptom approach.